Today we will be talking about the glomerulopathies and glomerulonephritis in detail. In the previous lectures, we discussed that once glomerular tissue is injured, what are the clinical presentations and clinical manifestations. Right? In the last lectures, we only discussed that once the glomerulus is injured, right, what are the clinical presentations? As we discussed, if there is minor injury to glomerulus, patient may come with proteinuria, or if there is more injury, patient may come with a nephrotic syndrome, or if there is more severe injury, patient may come with nephrotic syndrome, and so forth. But in the last lectures, we did not discuss that what are the mechanisms of injury to the glomerulus. Right? Let me define glomerulopathies and glomerulonephritis. Glomerulopathy means there are pathologies in glomeruli, and glomerulonephritis means that pathologies in glomeruli are inflammatory in nature. Pathologies in glomeruli are inflammatory in nature. Is that right? Now, in glomerulonephritis, there are so many types of glomerulonephritis, but all the glomerulonephritis are due to immune-mediated mechanisms. Right? Immune-mediated injuries involved. That is the primary mechanism of injury to the glomerulus. Right? Again, all the glomeruli involve the immune-mediated injury to the glomerular tissue. An immune system, when it is damaging the glomeruli, it also activates further secondary mechanisms of injury. So we have to see what are the primary immunological mechanisms of injury to glomeruli, then what are the secondary mechanisms of injury to the glomeruli, and then we have to also discuss that what are the morphological changes in glomeruli after the injury. Is that right? And eventually, what are the clinical presentation? Again, let me tell you, we have to discuss in 4 domains. Domain number 1 is that we have to answer the question that what is the primary immune-mediated injury to glomeruli. First, we have to answer this. What are the primary mechanisms of immune-mediated injury to glomeruli? Then we have to see that these immunological mechanisms which are attacking the glomeruli, they will activate secondary mechanisms of injury. They will activate secondary mechanisms of injury to glomeruli. Right? And next concept which you should build is that after primary and secondary glomerular injury, what are the morphological changes in injured glomeruli? What are the morphological changes? Logical changes in, injured glomeruli. Actually, on the base of these histological and morphological changes, we classify glomerulonephritis. So it means when we talk about the types of glomerulonephritis, the actually types of glomerulonephritis are classified on the basis of morphological changes on the injured glomeruli. Right? So we can say this will determine the types of glomerulopathies or glomerulonephritis. And in the end, now we know, for example, if we discuss this, we will be knowing what are the primary mechanisms of immune-mediated injury, we will be knowing what are the secondary mechanisms of injury to glomeruli, and we will be knowing that after these 2 injuries, what are the morphological changes in glomerular tissue, and according to that, what is a particular type of glomerulonephritis. As we know, there are many types of glomerulonephritis. There is minimal change glomerulopathy, there is membranous glomerulonephritis, there is membranoproliferative glomerulonephritis. I will discuss all them in detail. And eventually, we have to talk about the clinical presentations. Clinical presentations. That how these different type of glomerular diseases clinically present to you. And this part we have discussed in first and the second lecture. That glomerular injury, once glomerulus is injured, patient may come with non-selective, with selective proteinuria, or patient may come with non-selective proteinuria, or patient may come with nephrotic syndrome, or patient may come with nephritic syndrome, or patient may come with acute renal failure, or patient may come with chronic renal failure. This is what we have discussed, but we have to make the basis. And we have to correlate these concepts. In every glomerulonephritis, you have to have a concept that what is the immune mechanism, what are secondary mechanism of injury, what are the changes in glomeruli, and eventually due to those changes, what are the clinical presentation. Is that right? Now we go backward. We proceed backward and start discussing from here. Is that right? Let's see what are different type of immunological mechanisms which produce injury to glomeruli. Now, different immunological mechanisms which are attacking the glomeruli, of course, they must be having some antigen over there. That's the first thing, that there must be some antigen there. Because immune mechanisms are triggered against antigens. Is that right? There should be something in the glomeruli, right? And there should be an antigen there. Now we see that what type of antigens can be there. I will give you some different examples. In some cases, let's suppose this is the glomerular basement membrane, and here is your, what is it? Endothelial side. And what is here? Is that right? This structure is familiar to you? Now, and of course, here is what? Mesengium, isn't it? Now, let's suppose here is your immune headquarter. An immune headquarter has to produce antibodies or sensitized T cells against certain antigen. We start with a very basic concept. In some patients, there are the normal proteins which are normally present in the kidney, they become immunogenic. Again, listen carefully. Normally the proteins which are present in our kidney, do you think in a healthy person our own protein, our own kidney's protein activate our own immune system? Answer is no. Normally, physiologically speaking, the antigens which are normally present in your kidney, they do not activate your immune system. But sometimes, due to defect in immune system may attack your own antigens which are normally and naturally and intrinsically present within the glomeruli. Of course, it will be an example of autoimmune disease, isn't it? Now, one of the classical presentation is that in this glomerular basement membrane, you know there is a very special type of collagen present over here. What type of collagen is present in glomerular basement membrane? Type 4 collagen, right? There is type 4 collagen which is present in glomerular basement membrane. Now, this type 4 collagen is made of multiple peptides. Usually there are 3 peptides and they are intertwined together. And in the end of them, they are having, now listen, this is peptide chain. And in the end of that, this is a globular portion of peptide chain. This is suppose alpha chain. Multiple alpha chains, alpha peptide, twist together and make type 4 collagen. This is what? Type 4 collagen. And type 4 collagen is made of multiple peptide chains twisted together. Is that right? Now, this part of this peptide chain is called non-collagenous globular component of peptide chain. Globular component of alpha peptide chain. Now, in some patient, this component, this unique component may become immunogenic. May become immunogenic. What I mean by immunogenic means that this becomes capable of activating the immune system, right? Maybe due to some alteration in this component of the type 4 collagen, right? This is able to activate the immune system. And immune system starts making antibodies against this particular antigen, right? What immune system will start doing? It will start making just antibodies. These antibodies will come into circulation. These antibodies are directed against this particular non-collagenous component of type 4 collagen. Is that right? Now, listen. Type 4 collagen is present throughout the glomerular basement membrane or only in some areas? Throughout. Listen carefully. Type 4 collagen is present throughout the glomerular basement membrane because basic primary meshwork of glomerular basement membrane is made of type 4 collagen. Now, because type 4 collagen is present uniformly throughout in glomerular basement membrane, so it means this antigen is also present uniformly in GBM. Okay, I will call now onward glomerular basement membrane in the lecture as GBM. What is meant by GBM? Glomerular basement membrane. Right? Again, GBM is made of type 4 collagen. One component of type 4 collagen become immunogenic. This is our intrinsic antigen because it is not coming from outside, it is present within the renal tissue. It is our intrinsic antigen. Against this intrinsic antigen, immune system start making antibodies. Naturally, these antibodies will attack the glomerular basement membrane, and because antigen is present in a uniform fashion, so antibody will react in a uniform fashion. Right? Antibodies will be present throughout the GBM, right? So we can say that antibody attack on glomerular basement membrane will be in a linear fashion, Is that right? So this is one example in which glomerulus is being injured by anti-GBM antibodies. Is that right? Now we talk about another example. This is one example. Another classical example of cases in which intrinsic antigen of glomerulus become immunogenic is, okay, I will draw it here. GBM, and what is this? Podocytes. Is that right? Actually, in between the food processes of podocyte, there is a special protein present here, and these proteins are called megalins. These proteins are called megalin. In some patients, megalin proteins become immunogenic. Right? It means our immune system develops capacity to make antibodies against megalins. Is that right? Now, megalins are also our intrinsic antigen. Is that right? And once immune system will make antibodies against megalin, these antibodies through the circulation will come and react with the megalin. Now, megalin is present only in the depressions in between the podocytes. Do you think megalin is uniformly distributed? No, megalin is not uniformly distributed. Rather, it is distributed in a granular fashion. It is distributed in a, yes please, granular fashion. Is that right? Then, if antibodies are formed against the megalin, do you think those antibodies will be deposited in glomeruli in a uniform linear fashion, or those antibodies will be deposited in glomeruli in the granular fashion? Again, some antigen which is present in the depressions of in between the podocytes food processes, right? If against these antigens antibodies are formed and antibodies come and react with them, then deposition of antibody in the injured glomeruli is in a linear fashion like anti-GBM antibody, or deposition of antibody is granular in nature. It is granular in nature because lot of antibodies are present over here, then no antibody in this area, then again antibodies present over here, then no antibodies, then again antibodies present over here, no antibody, again antibodies present over here. So antibody deposition will be granular in nature. That will be granular in nature. But the things which are common in first example and the second example are that in first example also antigen was intrinsic to kidney. In second example also the antigen is intrinsic to the kidney. Right? In both examples, do you think you will find antigens present in the blood? No. It means blood will have only antibodies, but blood will not have antigens. In these patients, blood will have antibodies, but blood will not have the antigens. So blood will not have immune complexes, because whenever antigen and antibody both are present in blood, then immune complexes are circulating. When antigens and antibodies both are present simultaneously in the blood, then we say immune complexes are circulating. But in this example number 1 and example number 2, because antigens are fixed into kidney and antigens are not circulating in the blood, so blood cannot have immune complexes. Blood of the patient will have only antibodies. So do you think this can be immune complex disease? It cannot be circulating immune complex disease, right? Now, in these two examples, immune complexes are formed, but not in circulation. Immune complexes are found within the glomeruli. In these two cases, immune complexes are found only within the glomerulus. We say that there is in situ formation of immune complexes, right? This is an example where there is in situ formation of immune complexes. There are no circulating immune complexes, right? In situ mean that the point where the injury is going on, immune complexes are formed exactly at that very point. Is that right? Because antigen is fixed into those points and antibodies approaches there. Any question up to this? Michael, you are clear? Right. Now, after discussing two examples, let's suppose now we will again primary immune complexes. Immune mediated injury may be antibody mediated injury. Antibody, this is antibody mediated injury. Now antibody mediated injury again has subtypes. In situ immune complex formation or deposition of circulating immune complexes. Immune complexes. In situ immune complex formation mean antigens are within the glomeruli, and exactly at that point what happens, that reaction is occurring. And the classical example in this case, we talked about one example in which you developed anti-GBM, yes, anti-GBM antibodies, right, against type 4 collagen. Is that right? And in this case, antibodies were deposited in a very linear fashion. Is that right? Anti-GBM antibodies. Second example we took was in which yes, antigens are present in certain pets. So antibodies reacted only at those points. So naturally there was granular pattern of antibody deposition. Is that right? This type of glomerulonephritis is also called Hayman's glomerulonephritis, Heyman, Hayman's glomerulonephritis. This is the second mechanism. The common thing in these two is that antigen is intrinsic. What is common thing about that? That the antigen is intrinsic. Is that right? But sometimes what happens, that antigen may not be intrinsic, antigen is circulating, and before the antibodies come, antigen deposits in, this is another example, in which antigens planted in glomeruli. How it can occur? Let me tell you. There is, let's suppose, some antigen which is circulating, and yet antibodies are not formed in the body. And this circulating antigen eventually deposits in glomerular components. The circulating antigen eventually deposits in glomeruli. Now this circulating antigen may deposit within the, what is this, GBM, or this may deposit in subepithelial area, or it may deposit in subendothelial area. Let me make a large diagram so that you really understand. Now we are going to talk about some antigens. We are going to talk about antigens which are not intrinsic to the kidney. Rather, these antigens were circulating in the blood, and eventually they settle down into glomeruli, right? But these antigens were circulating in the blood alone, yet antibody formation was not there. So first antigen will deposit, later on antibodies will follow them. Is that right? Now let me explain that how this process occurs. What is this cell? Yes, please. Endothelial cells. And what are these cells? Yes. Yeah, or visceral epithelial cells. And of course, no fun in explaining what are these, friends? Yeah? Mesangial cells. Am I clear? Now, in this particular case, what we really see that from the blood circulating antigen come. Now, antigen may deposit under the endothelium or into basement membrane or between the basement membrane and epithelium. These are three areas, right? And fourth area is antigen may get deposited in mesangium. Again, listen. For example, you have some antigen circulating into blood, and eventually this antigen gets deposited into glomerular tissue. Now, what are the choices? If antigen is very large in size, and antigen is negatively charged, do you think it can pass through the membrane? No. So this will be deposited, larger antigen will be deposited just under the endothelium. So we say that there are subendothelial deposits of the antigen, subendothelial deposit. If antigen is little smaller, it may go up to glomerular basement membrane. If antigen is smaller and positively charged, it may pass through all the layers and this get deposited into between the glomerular basement membrane and epithelial cells. So antigen, depending upon its size, depending upon its charge, it may be deposited subendothelially, or it may be deposited intramembranously, or it may be deposited subepithelially. That is why when we discuss different type of glomerulonephritis, we talk about that one type of glomerulonephritis may have intramembranous deposits. The other glomerulonephritis which have subendothelial deposits. There are still other types of glomerulonephritis which have subepithelial deposit. And of course, we should not forget, in some glomerulonephritis, deposits are intramesangial. Of course, don't forget this place. Intramesangial. Is that right? Again, if antigen is larger, it will stick into subendothelial area. If it is smaller, it may go up to subepithelial area, right? And also it depends on the charge, right? If antigen is negatively charged, it will be repelled by the normal negative charges in the GBM, and it may be deposited only in subendothelial area. But if antigen is positively charged, it may be attracted by the negative charges and it may go into deeper layers up to subepithelial area. Is that right? But this antigen, which these are coming from circulation, they are not normally healthy component of the kidney. So we say these are planted antigens. What we call them? Planted antigens. What could be these antigens? These antigens may be our circulating endogenous antigens. For example, in some diseases like SLE, cells are damaged and DNA comes out. And double-stranded DNA as an antigen get deposited here. And our own DNA, which was circulating unfortunately, again listen, have you heard of the disease SLE? Systemic lupus erythematosus? Okay, in that disease, there are many autoantibodies which react against multiple tissues. And multiple cells in the body are damaged. And from the cells, from the different cells, DNA may leak into blood. And that circulating DNA may get stuck into kidney. And in the kidney, it may act as antigen. And later on, anti-DNA antibodies may follow and produce glomerulonephritis. Is that right? This is one scenario. In SLE, one more scenario can occur. That in the blood, DNA is circulating, and in the blood, anti-DNA antibodies make immune complexes. So DNA, anti-DNA complexes together deposit there. Both things can happen. But right now we are concentrating only that some circulating antigen gets deposited into glomerular area, right? From where it will be deposited, it may be deposited intramesangially, it may be deposited subendothelially, it may be deposited intramembranously, it may be deposited subepithelially. But the question is that from where these antigens come to glomeruli, right? These antigens are coming from blood, but in the blood from where they come? These antigens in the blood may be our own antigen from other tissues. If they are our own antigens from some other tissues in the body, we call them endogenous antigens. Endogenous circulating antigens are getting deposited. Or more often, these are exogenous antigens which enter in our body. For example, some microbial antigen, some viral antigens are present in the blood, right? Hepatitis B surface antigen, or hepatitis C antigen, or there may be malarial, plasmodium antigen, or there may be treponema pallidal antigen, or there may be streptococcal antigen, or there may be some drugs related antigens like penicillamines, or there may be heavy metals, or there may be some bee sting toxins. All these are foreign antigens which may be microbial in origin, or they may be pharmacological in origin, or they may be toxic in origin, toxins. Sometimes in some patients, these circulating antigens unfortunately get planted into glomeruli, and later on, if antibodies are formed against these things, the antibodies will happily go to where? Glomeruli. And antigen-antibody complexes are formed within the glomeruli. And you know what will happen? When two bulls are fighting, who suffers? Okay, it's a simple question for your high IQ. When two bulls are fighting, not bulls, even elephants are fighting, two big elephants fighting, who will suffer? Grass. Is that right? In the same way, when antigens and immune system is fighting in the glomeruli, who suffers? Glomerulus. So you are talking about from where they come to fight. Is that right? If antigen is the elephant, some elephants are our own elephants, intrinsic elephant of the kidney. Right? And other elephants come from the immune system to fight there, and glomeruli suffer. Or some elephants are coming, circulating, and then settle over there. These are planted elephants, and then antibodies come. And some elephants, while circulating, they were fighting on the way, they get stuck there. We'll talk about that later. Now, from where these antigens are coming? My friends have to tell me immediately. Planted antigens. They may be coming from circulation, they may be endogenous antigens, or they may be exogenous antigens. Exogenous antigens may be, yes please, maybe microbial in origin, or maybe drugs related antigens, or they may be toxin related antigens, right? And it means so many different things can produce glomerulonephritis. Now you may be thinking, Why I am stressing so much small things? The reason being, you may come across a patient who has nephrotic syndrome. Before really I proceed, I want to tell you how mind of a doctor should work. Patient comes with nephrotic syndrome. Is that right? That is what you can diagnose. There's a lot of generalized edema and you check protein in the urine, proteinuria, hyperalbuminemia, hypercholesterolemia. Okay, nephrotic syndrome. But it's not enough to diagnose nephrotic syndrome. It's not complete diagnosis. You must know what type of changes are in the glomeruli. For example, you do biopsy of his glomeruli, biopsy of the kidney, of the patient of the nephrotic syndrome. Under the microscope, you look at the glomerular basement membrane, which is very thick. Glomerular basement membrane in this patient, let's suppose, is very, very thick. If glomerular basement membrane is very thick and there's no other significant change, you say, okay, because membrane is thick, I should label the patient as membranous glomerulonephritis. Now you have two-step thing. Patient has nephrotic syndrome and cause of nephrotic syndrome is membranous glomerulonephritis. It means membrane is thick. That's it. Now, why membrane is thick? Maybe some antigen is deposited or antigen antibodies are deposited there. Some immune reaction. Now you have to think, what could be the antigen? Right? Now, when you start, if you are really good doctor, you must know that antigens may be endogenous or exogenous. And you have to do many tests to rule out exogenous antigen. Or you have to take his drug history. Or you have to take the history of microbiological infections. Or you have to take a history of some toxins ingested. Patient has come with nephrotic. You have done the biopsy, you find membranous changes. But this is again not complete diagnosis. You know clinical presentation is nephrotic, you know the morphological changes in the injured glomerulus is membranous. But what was the mechanism of injury? What was the cause of injury? Then you have to do the test. Maybe you have to check the Plasmodium falciparum presence or absence. You have to check hepatitis B surface antigen. Maybe you have to check the hepatitis C antigen. Maybe you have to check for Treponema pallidum antigen. Maybe you have to take history which drugs he is taking. Right? During all these tests, you suddenly come to know that he is having chronic malaria. He is having chronic malaria. So it's quite possible that due to chronic malaria, his blood was having plasmodial antigens, and plasmodial antigens were being showered on the glomeruli, and this unfortunate patient was getting these planted antigens. At the top, he developed antibodies reacted there, and those antibodies activated some secondary mechanism like complement system, and glomeruli get injured. And because antigen antibody was deposited in the membranes become thick, and epithelial cell become angry with this fight, they produce more GBM, and it become more thick. So from where you have to start the story? You have to keep working backward. From where? What is the clinical presentation? In this patient it was nephrotic syndrome. Then you go back. You do biopsy and immunofluorescent studies. I will tell you what are immunofluorescent studies. You come to know it's membranous. Then you have to go back. By immunofluorescent studies you can determine what is the secondary mechanism of injury. Are there complement deposited there or not? And then you have to look for immune mechanisms. And then you have to look for the, antigen. Because if patient is suffering with the nephrotic syndrome due to malarial, then anti-malarial should be given. But if he is having treponemal chronic infection, then anti-treponemal treatment is there. And if he was taking some drug, penicillamine, and that drug was depositing and reacting with the glomerular proteins and making them immunogenic, then drug should be stopped. Is that right? So why it is so important to understand all this, that concept is built, should be built like this: antigen, immune reaction, secondary mechanism of injury, types of glomerulonephritis, and clinical presentation. This is how we should understand. But how mentally we work when patient come in reverse direction. We have to diagnose what clinical syndrome patient is coming, what type of morphological changes and type of glomerulonephritis is there, what are the underlying mechanisms of immunological mechanisms of injury, and what are the antigens which are triggering, and how we can manage that. Is that right? In many cases of glomerulonephritis, we are unable to find the antigen. Then we just give, if we cannot eliminate the antigen and we cannot eliminate the trigger, what we do? We suppress the immune system with with the steroid drugs or with cyclophosphamide and other, so that we try to suppress at this level so that problem should not go there. Is that right? So why I made a little small speech about this? Because I felt that you should know why we are studying all this topic in particular fashion. Right? Because your mind has to work like that in future. Now, let's go back. We were still stuck with the very early phase. That immune reactions against the antigen. And we only discussed up to this, antigens may be, number one, antigens may be intrinsic to the glomeruli. Intrinsic antigen may be GBM antigens, or they may be Magellan type antigens. Is that right? If GBM antigens, there is linear deposits of antibodies. If the Magellan type or subepithelial deposits, Magellan type antigens, then there is granular antibody deposits. Clear? Then we talked about that antigens in some glomerulonephritis may not be intrinsic to kidney. Antigens may come from the circulation. Then we talked about those antigens where they will be deposited. Those antigens may be deposited intramesangial or subendothelial or intramembranous or subepithelial. Why I talk about their deposition site? The reason being, in first case we said antibody reaction will be only in GBM. Here will be only in subepithelial area. But in this type of antibody will come and react at the site where the antigen is already planted. Is that right? Because if antigen is here, then mesangial damage will start. If antigen is here, then maybe antibody come and react and produce, damage the endothelial cells, and you develop thrombus formation. If antigens are here, maybe these cells will detach and there is increased permeability. Am I clear? Right? Now, so planted antigens. After that, we go one more step. Sometimes what happens, that antigens and antibodies both are circulating together in blood. Sometimes antigen and antibodies both are circulating in the blood simultaneously. So naturally, they will make antigen-antibody complexes, which are also called immune complexes. Now, this is next scenario. For example, someone has hepatitis B surface antigen in the blood. At the same time, he has antibody related with that. So antigen-antibody complexes form, and they may get stuck into glomeruli. Or someone has streptococcal infection, and streptococcal infection is leading to some streptococcal antigenemia. That streptococcal antigens may be present in the blood. And then anti-streptococcal antibodies in the blood react with the antigen, and immune complexes are formed in the circulation, and then they get deposited over there. In this case, do you think immune complexes formed within the kidney, or it was pre-formed in the blood and got stuck into kidney? Pre-formed. So this cannot be example of in situ immune complex formation. This will be called simply immune complex disease. What will be it called? Immune complex disease. It is, previous example was in situ immune complex formation. These are circulating, yes please, circulating immune complex disease. Right? Here you can understand, diagram should be very simple, that there is antigen in the blood and antibody also in the blood. And both of them get deposited into where? Glomeruli. So we say this patient has circulating immune complexes and they get deposited over there. Naturally, circulating immune complexes may be larger. So more often they will be deposited subendothelially or subepithelially. Subendothelially. In circulating immune complexes, diseases, immune complexes are making large complexes, and most of these large complexes are deposited in the glomeruli just under the endothelium. Most of these complexes are unable to go into deeper area. Is that right? So, in circulating immune complex diseases, when glomerulonephritis occurs, in such type of glomerulonephritis, the deposits of the immune complexes are more frequently in which area? Subendothelial area. Any question up to this? There is no question. Right? This is subendothelial deposits. This type of deposits are classically seen in SLA. Now here, I would like to mention one more thing. Have you heard of hypersensitivity reactions? How do you classify hypersensitivity reaction? Of course, she knows there are 1 type, 2 type, 3 type, 4 type. That's right, there are 4 types of hypersensitivity reaction. What is your concept of hypersensitivity reaction? What is hypersensitivity reaction? If you are sensitive to someone's presence and you become angry, this is hypersensitivity reaction. This is also emotional hypersensitivity reaction. I'm talking about immunological hypersensitivity reaction. Have you heard of this term or never heard of it even? You've heard of it. What is hypersensitivity reaction? I will go back to this discussion, but I want that you should have some basic concept about hypersensitivity reactions. There are basically type 1, yes, type 2, type 3, and type 4. Type 1, 2, and 3. These are antibody-mediated hypersensitivity reaction. And type 4 is cell-mediated hypersensitivity reaction. But what are hypersensitivity reactions? Yes, please. Okay, write it down. Any tissue-damaging immune reaction is called hypersensitivity reaction. That's so simple. Any immune reaction in our body which damages our tissue, any immunological reaction in our body which damages our tissue should be called, yes, hypersensitivity reaction. Now look, in this context, we say glomerulonephritis is a group of diseases. Remember, glomerulonephritis is not one disease. It's a very big bag of diseases and many diseases are put into that. But the common thing is that all these diseases are immunologically damaging the glomeruli. Is that right? So, we define hypersensitivity reactions as tissue damaging immune reaction. And we define glomerulonephritis as immune-mediated damaging diseases to glomeruli. Is that right? So it means that glomerulonephritis should be hypersensitivity reactions. Is that right? Now, hypersensitivity reactions are 4. Just very briefly, I'm not going to give lecture on hypersensitivity reaction, but at least you must know as good doctors the difference between them. What is type 1 hypersensitivity reaction? Oh my God. Type 1 hypersensitivity reaction has antibody always IgE. Antibody is always IgE. Okay. Antibody in type 1 hypersensitivity reaction is always IgE, and antigen in type 1 reaction is always extrinsic, exogenous. Type 1 reactions are always against the antigens which come out of the body. Is that right? If some antigen come into my body, it may be pollen or it may be drug or it may be anything, come into my body and I make IgE against that, that reaction should be called type 1. And because IgE bind with the mast cells, and when antigen come, mast cells are activated and mast cells produce the product which produce the damage. When antigen come, it react with the IgE which is already loaded on mast cell. For example, if I have type 1 hypersensitivity reaction against the penicillin, then I will have anti-penicillin IgE loaded already on my mast cells. When antigen come and react with the IgE which is preloaded on the mast cell, then mast cells degranulate and produce a lot of product, and those products do damage to us. So we say mast cells are the effectors of injury. Mast cells are the effectors of injury. Am I clear? Now, this is type 1 hypersensitivity reaction in very brief, because I just want you to know the difference in type 1 and type 2. In type 1, antigen is always exogenous, and antibody is always IgE. Thank you very much. Of course, effector system is mast cell. Clear. Type 2, antigen is always endogenous. In type 2 hypersensitivity reaction, antigen is always endogenous, and more specifically speaking, antigen is always intrinsic to the membranes where reaction is occurring. If you really want to be excellent doctor, then in type 2 hypersensitivity reactions, antigens involved in these hypersensitivity reactions are always intrinsic to the membranes and tissues to which hypersensitivity reaction is occurring. So what we say? Antigens always what? Endogenous, more truly speaking, intrinsic. Intrinsic to tissue under attack. Tissue under attack. Of course, if this is an antibody, let's suppose this is glomerular basement membrane, and this is an antigen intrinsic to the glomerular basement membrane, and then antibody react and produces damage by complement activation or produces damage by some cell activation or whatever mechanism. But this has to be which type of hypersensitivity reaction? Type 2. In type 2 reactions, antigens are fixed into the tissues to which attack will occur. Antigens are intrinsic to the tissues to which attack is going to be there. So do you think in type 2 hypersensitivity reactions, antigens will be freely circulating in blood? No. So can this be free circulating immune complex disease? No. In type 2 hypersensitivity reaction, only a specific tissue will be damaged. Is that really clear? Okay, I'm impressed by you. Now, type 3 hypersensitivity reaction. Look again. Type 1 was, antigen was always exogenous and antibody was always Ig. Type 2, antigen was always intrinsic to the tissue to which attack occur, and antibody was always IgG or IgM. Right? Here it was IgE. Here effector system was mast cells. Here effector system may be complement system, or effector system may be neutrophil or some killer cells. Is that right? Really clear? Type 3 hypersensitivity reaction. Of course, good doctor should know how the type 3 differ from type 2 and type 1. Type 3 has antigens which are not fixed into tissue. Type 3 has antigens which are free. Antigen in circulation. Now again listen. This is a very important concept. In type 1 reaction, antigen may be free. Coming from outside, it may be free into fluids. But in type 1 reaction, antibody is fixed on the mast cells and basophils. Look, there is a policeman and there is a thief. Right? In type 1 reaction, policeman is fixed on the police station. Ig is fixed. Somehow thief reaches there and problems start. This is a stupid type of thing, but it happens. Is that right? Type 1 hypersensitivity reaction, antibody is fixed, antigen is exogenous and free. In type 2, antigen is fixed, and who approaches that? Antibody. In type 2, thief is fixed. He's stuck into his certain place where probably he was doing some activity, and policeman approaches there. Is that right? In both cases, you will not find police and thief fighting on the roads. It means you will not find antigen-antibody complexes in both cases into circulation. Because in one place, police was stuck into police station and thief enter into police station, maybe take something away. I don't know. Stupid. Right? Or in type 2 hypersensitivity, what is happening? Thief is somewhere stuck, not on the roads, and police gets the reports and reaches there. And type 3, thief is moving on the road. And police is also moving on the road, so they get stuck over there. So that thief and police complexes are formed, antigen-antibody complexes. And they're fighting on the roads, on every road. So do you think one tissue will be damaged or multiple tissues will be damaged? Of course, multiple areas in the town will be injured when there's a big fighting going on between police. Is that right? So that is called immune complex disease. That is why in type 2, only specific tissue is injured. Because police will only attack on specific area where thief is stuck. But in type 3, antigens are free and circulating, and antibodies are also free and circulating. So they make what? Immune complexes present in circulation. Is that right? In type 3 hypersensitivity reaction, antigen-antibody complexes are pre-formed in circulation and then they get deposited into multiple tissue. Some of them may get deposited into glomeruli and produce glomerulonephritis. Some of them may get deposited into synovial membrane and produce arthritis. Some of them may get deposited into pericardial membrane and produce pericarditis. Some of them may get stuck with the pleural membrane and produce pleuritis, pleuritic pain. Some of them may get stuck under the skin vessels and produce vasculitic lesions in the skin or rashes in the skin. Is that right? Now listen carefully. If someone comes with glomerulonephritis and he has also some rashes and he has some polyarthritis, and with that he may have pleuritic pain. What do you think? What type of reaction is going on? Immune complex type 3. You don't need high IQ to answer it. Isn't it? All of you could answer it. Right? Now, what I'm saying, this is type 3 hypersensitivity reaction. Right? Type 4 hypersensitivity reaction does not involve antibodies. It involves only lymphocytes, and in association with macrophages they produce the product and damage the tissue. I will not go into detail. Any question up to here? Now come back. I said that antigens may be intrinsic to the glomerulus. Maybe antigens may be belonging to the type 4 collagen, or antigen may be belonging to some protein normally present in the pits between the food processes. Now, when antibodies react in these two fashions, it is what type of hypersensitivity reaction? Type 2 hypersensitivity reaction. So this glomerulonephritis, this one or that one, that will be an example of type 2 hypersensitivity reaction. But if antigens get planted over there and antibodies follow there, what is that? There is no IgE. Antibodies are usually IgG or IgM. Yeah, it cannot be strictly speaking type 2. Is that right? And until immune complexes don't form, this is not type 3. But usually in these cases, first antigens come here, eventually antibodies form. And antibodies may catch some circulating antigens also. Then this may convert into type 3. Then, in some patient, antigen-antibody complexes were circulating in the blood, and some of the complexes get deposited into glomeruli and damage the glomeruli. What is that? Type 3. Now it's so easy to talk that if complexes are very less, patient will come with proteinuria. If complexes are more and injuries more, patient will come with nephrotic. If complexes are very heavy concentration and damaging too much, this may be nephritic. You get it? How these concepts can be correlated with those concepts. Is that right? Patient will not come and say, you see, antigen has come to my glomeruli and now complements are activated, I have membranous glomerulonephritis. You are the doctor, you are supposed to find out what's wrong with the patient. Is that right? Now, we have talked about some of the antibody-mediated injuries, right? Now we'll talk about some more things about the mechanisms by which immune system can injure the glomeruli. I'll make it simple. Any question?